The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks to everyone for listening in. As I promised, I am following up this week with a very in-depth review of risk adjustment data validation, or RADV Audits, in Medicare Advantage. I briefly mentioned this in last week's podcast as one of the recent healthcare developments beyond the passage of the One Big Beautiful Bill. As some background, many Medicare Advantage opponents, including the congressional policy arm MedPAC and some academic researchers, are arguing that MA is heavily overpaid. I have tremendous issues with these extreme calculations, which often include a deliberate congressional policy decision to pay more in rural counties and to ensure the success of the STAR program by adding dollars to be paid out for quality bonuses, as well as inclusion of dubious data on beneficial selection. So I throw a lot of those figures out the door. I am not arguing that there is not overpayment in MA, just that it's not as much as what's being advertised. Where opponents are closer to the mark is on overpayments derived from risk adjustment. I say closer to the mark because many of the critics argue that any reimbursement in MA that is over the traditional fee-for-service program levels is somehow nefarious. It is not true. Providers in the traditional program do not have an incentive to code properly, as they get paid on individual claims and need only to supply a relevant diagnosis code to get that payment. In MA, plans work to ensure that all diagnoses are captured in the risk adjustment system. So some differential in RA scores between the programs actually makes sense to me. But there clearly are suspect or even fraudulent risk adjustment scoring going on in MA. That is what I think needs to be reined in. And as I will note later, it is not really every plan, but actually is limited to a handful of plans, most of them bigger ones. And these handful of plans get the most benefit out of the risk adjustment system, but casts a pale over all MA plans and the whole program. This has led CMS and lawmakers to begin to dig into the issue and get serious on possible reforms. While it did not happen, some lawmakers wanted to put MA overpayments as savings in the budget bill. There are discussions now about a second bill and perhaps adding MA overpayments there as well. Enter the recent announcement by the Centers for Medicare and Medicaid Services, which attempts to, in part, tackle this actual problem of overpayment in the risk adjustment system, in my view. So I support the concept of the RADV audits that CMS is proposing. Later, you will learn, though, that I do think the government's approach to RADV may not be entirely fair. We will take 3 breaks to break this rather complex subject up, so let's get right into the meat of the podcast on risk adjustment data validation audits, or RADV audits. In a bombshell announcement in late May, the Centers for Medicare and Medicaid Services said beginning immediately, it will audit all eligible Medicare Advantage plans for each payment year in all newly initiated audits and invest additional resources to expedite the completion of audits for payments years 2018 through 2024. MA opponents and a bipartisan group of lawmakers again have raised issues with what they view as immense overpayments, some of which are tied directly to risk adjustment scoring. CMS says risk adjustment overpayments are about $17 billion a year. Richard Kronig and his colleagues at the University of San Diego find that risk scores are 18.5% greater in MA in 2021, amounting to $33 billion a year. The Medicare Payment Advisory Commission estimates the risk scoring overpayment figure could be as high as $43 billion per year. MedPAC says total overpayments are $84 billion per year. And as I noted, others have numbers over $100 billion annually. As I noted, I often dispute MedPAC's and other research's total overpayment numbers. They seem based on flawed or limited data and are tinged with bias. I've made the case that some risk scoring above the traditional program is fair, given fee-for-service program providers lack an incentive to report all diagnoses. But I do find that a small group of MA plans have aggressive and aberrant behavior in terms of risk adjustment submissions. Further, there are a number of whistleblower and Department of Justice cases that allege far-reaching fraud in risk adjustment. CMS has had an extremely poor track record on carrying out risk adjustment audits and recouping revenue. CMS admits the agency is very behind in conducting such audits and recouping overpayments. The last significant recovery of MA overpayments occurred following the audit of payment year 2007. CMS has a plan to complete all remaining RADV audits for payment year 2018 to 2024 by early 2026. Key elements of the plan include enhanced technology for medical record review to flag unsupported diagnoses, and a major workforce expansion to boost medical coders from 40 right now to 2,000 by September 1. CMS says it will be able to increase its audits from about 60 MA contracts a year to all eligible MA contracts each year in all newly initiated audits, approximately 550 contracts. The coders will manually verify flagged diagnoses to ensure accuracy. CMS is expanding its reviews in another way. It will increase reviews from auditing 35 records per MA contract per year to between 35 and 200 records per MA contract per year based on size. The reform was driven by a few emerging trends. First, the Trump administration is looking for a huge sum of dollars to reduce the budget over time. The overpayment issue has been tagged by conservative think tanks and incoming administration officials as a major issue to tackle to reduce spending. Second, a growing number of lawmakers on both sides of the aisle have called out overpayments as corporate welfare to MA plans. Third, CMS Administrator Dr. Mehmet Oz promised to go after MA overpayments at his 2 confirmation hearings. Oz committed to 100% auditing of plans quickly. With that, we will take our first break, and when we come back, we will tell you more about risk adjustment, RADV audits, and more details on the new 100% audit announcement recently made by CMS. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you are enjoying this edition of the Healthcare Labyrinth Podcast. We're talking about risk adjustment and RADV audits. A recent announcement by CMS ups the risk to MA plans about recoupment of revenue in the MA program. So you might be wondering exactly what is risk adjustment. Well, in Medicare Advantage, there is a demographic part of the rate setting system, which takes into account things like age, gender, and certain demographics, such as Medicaid status. But also there is a clinical component that risk adjusts the rate further for the health of the individual. Quite simply, it rewards plans with additional revenue if an enrollee is sicker than the average, and less revenue if the enrollee is healthier than the average. The enrollees are given the clinical component that is based on various diagnoses of an individual, and in some cases, the severity of certain illnesses as well. This is essentially put into the overall rate setting system with the demographic component to ensure that the health of the member is adequately recognized. What is a RADV audit? Well, CMS already adjusts rates downward by putting a coding intensity adjustment on MA rates each year. But to further attack what it sees as the perceived issue of overpayments or risk adjustment inflation in the Medicare Advantage program, it added a new and controversial risk adjustment data validation rule in process that was finalized in 2023. The rule stemmed from earlier pilot audits done by CMS and the Department of Health and Human Services Office of Inspector General on a pilot or ad hoc basis. In these new individual audit processes, the government will send a sample to a plan. Plans will need to provide documentation of diagnoses submitted via encounter data or supplemental submissions. CMS can now extrapolate penalties based on a sample audit's errors. What does this mean? Based on the error rates in the sample, CMS and the HHS-OIG, both can conduct audits under the rule, could calculate penalties across the entire membership and revenue, or a substantial portion of members depending on the sample scope, as if the errors occurred throughout the enterprise. So poor risk adjustment policies at a plan could lead to huge recoveries, billions across the industry. The RADV rule also gives CMS significant flexibility on what plans and the encounters the agency audits, although the CMS press release says they will audit every plan every year. Audits could be focused on contracts at the highest risk for improper payments. Diagnoses and type of beneficiaries, subpopulations may be singled out if they are at the highest risk for improper penalties. Extrapolation would be narrowed to these groups if that is undertaken. This is, for example, how payment year 2018 is being done and will also occur in the recent announcement on 100% audits for 2019. So here are some of the more specifics on that payment year 2019 announcement. Quickly after the main bombshell announcement of 100% RADV audits, CMS in mid-June announced round 1 of payment year 2019 RADV audits. In late June, the agency announced round 2. Round 1 has 45 contracts. Round 2 has 310. That means that almost 50% of now 732 contracts live in that year already have audit notices. According to the proposed instructions and methodology, there is only one major change from its payment year 2018 approaches. We'll talk about that in a few minutes. Payment year 2018 started in late 2024, and the audits are now concluded on the plan side. But the payment year 2018 frequently asked questions indicated that results would not be made until mid-2026. Will these be accelerated as CMS says they will have results for payment year 2019 in early 26? Or will CMS take time to look at both years together? Like payment 2019, CMS uses a high-risk suspect audit approach for payment year 2018. More later. In round 1's 45 MA contracts, you see a number of big name plans: Cambia, a Northwest Blue, Elevance Health, Humana, Molina, Scan, United Healthcare, and Centene WellCare. Risk-adjusted payments for payment year 2019 were derived from diagnoses from face-to-face medical encounters with dates of service. 2018, round one deadlines were swift. The payment year 2019 audits began immediately in mid-June. Enrollee data lists, which has each member and the HCCs being audited for each, were available as of 6/12/25. Medical record submissions commenced on 6/20/25. Records must be submitted by 9/15/2025. And again, CMS expects findings in early 26. Round 2 had deadlines that were roughly 2 weeks later than round 1. The audits will focus on risk-adjusted payments that CMS believes may be at higher risk for overpayments, as I've said. Specifically, the samples represent those ranked in the top decile of the improper payment predictions model. That is, predicted to have the greatest reduction in the risk score as a result of a RADV audit. CMS says they then used a statistically valid random sample of 35 enrollees each. For payment year 2018, this same high-risk approach was used, but in addition, CMS also reviewed enrollees who had all of their HCC submitted derived from a linked or unlinked chart review. CMS describes in some detail the extrapolation process that would be used to assess penalties. It says risk adjustment discrepancies are aggregated for sampled enrollees to determine the average change in sampled enrollees' risk scores as a result of the RADV audit. This is then used to estimate an overpayment amount for collection for the sampling frame using a statistically valid extrapolation technique. So CMS really isn't telling us much about the extrapolation process, except that since this is a narrow focus sample of high risk, the extrapolation will be focused on that cohort and not across the entire population. Plans must submit at least one valid medical record to support each audited CMS HCC. For each sampled enrollee, the plan can submit a maximum number of medical records equal to 2 times the number of audited HCCs. If a sampled enrollee has 3 audited HCCs in the EDL, the maximum number of medical records a plan can submit for that enrollee is 6. A plan may submit up to 6 medical records in any combination for the 3 audited HCCs. This policy appears more limiting than in the last. In effect, the average number of medical records that can be submitted for each HCC is 2 now. For payment year 2018 and prior, the count was 5 per HCC. CMS does a good job explaining the cover sheet and the medical record requirements. One medical record could substantiate more than one audited HCC, but must be clearly marked as so. Medical records lacking the necessary provider signature and/or credentials require a signed attestation to be considered valid and eligible for review. If a medical record file and cover sheet combination is determined to be invalid, the plan may submit another one to replace it if the medical record submission window is still open. CMS encourages plans to submit cover sheets and medical records as accurately and as early as possible. CMS will provide daily feedback and publish a feedback report. Medical record file and cover sheet submissions determined to be valid will be sent to the diagnosis code abstraction process. Each submitted valid medical record may be subjected to up to 3 rounds of review by certified medical record coders. A plan experiencing an extraordinary circumstance may request a hardship exception as well. With that explanation of the announcement, we will take our second break, and when we come back, we will tell you about some of the overpayment culprits out there and discuss whether the proposed RADV audits are indeed fair. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you are enjoying this edition of the Healthcare Labyrinth Podcast. We're talking about risk adjustment and RADV audits. A recent announcement by CMS ups the risk to MA plans about recoupment of revenue in the MA program. So who are the culprits in risk adjustment overpayments? Well, I told you earlier that the University of San Diego researchers estimated that risk adjustment overpayments were about $33 billion in 2021. They also found that the suspect coding revenue varied widely by MA plan. It found that United Health Group's MA market share was 27% in 2021, but United received 42% of that $33 billion sum of revenue, about $13.9 billion. United's estimated per member revenue increase was $1,863, and that was the biggest, with the MA industry average being about $1,220 per member. They also found that chart reviews and home-based health risk assessments accounted for about half of the difference in MA risk scores with the fee-for-service program. The San Diego research's conclusion is backed up by other studies. A study published in Health Affairs found that MA plans that conduct in-home and other HRAs are adding considerably to revenue through coding diagnoses from these encounters. The study, based on 2019 data, found that when an HRA is present, risk scores increase by about 12.8% on average. Restricting their use for such purposes could save between $4.5 billion and $12.3 billion. The HHS-OIG, which studied HRAs for the 2017 calendar year, determined that diagnoses reported only on our HRAs and no other service records that year led to an estimated $2.6 billion in additional risk-adjusted payments. The HHS-OIG came back in late 2021 with an additional study using the same data from 2016 and combining the HRA issue with manual chart reviews. It found that 20 of the 162 MA plans drove a disproportionate share of payments related to diagnoses that were reported only on chart reviews and HRAs and no other service events. HHS-OIG pegged the overall universe of potential overpayments across all the plans at $9.2 billion. HHS-OIG said that the higher share of payments to the 20 plans could not be explained by their enrollment size. This was the point made also by the University of San Diego researchers. The companies generated payments that were more than 25% higher than their share of enrolled MA beneficiaries. The 20 companies drove 54% of the $9.2 billion. One company drove 40% in the HHS-OIG study of the total amount. Like with the University of San Diego, that was United Health Group. Is what CMS and Dr. Oz are proposing fair, and will it work? I certainly support the proposal to invest at CMS in 100% RADV audits. Audits should be comprehensive and timely, Recouping true risk score overpayments is certainly fair. There are bad actors on risk adjustment that disproportionately benefit from revenue and give the entire industry a bad name. But the RADV rule finalized in early 2023 is very controversial. The rule is being challenged by several MA plans, including most notably Humana, due in part because of some legally questionable provisions put in by the Biden administration. More lawsuits are inevitable with the recent CMS 100% RADV announcement. CMS would have to use the 2023 rule to conduct the audits. Based on what has happened over the past few years, MA plans' concerns regarding benefit stability and the impact on bids are not unreasonable. Numerous due process, adequate notice, selective enforcement, regulatory scope, and other legal issues are ripe here for court challenge. The plans argue that the rule is inconsistent with previous policies and may lead to underpayments to Medicare Advantage organizations. Plan complaints and legal challenges center on the following. First, does the RADV rule's scope exceed CMS's authority? In the post-Chevron legal world, it very well could. Second, concerns have been raised about the consistency of the audit methodology, including the selection of high-risk diagnoses for review and whether the audit methodology is aligned with the risk adjustment model and actuarial equivalence requirements. Third, does CMS have the legal ability to extrapolate penalties across the entire membership? It says it does this in other areas, and will the methodology be fair and sound? It did not publish the exact methodology. Fourth, plans are also concerned about the significant flexibility given CMS on what plans, contracts, and the encounters the agency audits. As with payment year 2018 and the payment year 2019 announcements, audits can now be focused on contracts at the highest risk for improper payments. Diagnoses and types of beneficiaries or subpopulations may be singled out if they are at the highest risk for improper penalties, but admittedly, extrapolation would be narrowed to these groups as well if undertaken. Is this appropriate, though? Could targeted audits and extrapolating penalties across high-risk subpopulations actually cost plans more money than more comprehensive RADV approaches? Fifth, the fee-for-service adjuster in the RADV formula was eliminated. It was in CMS's 2012 RADV methodology and deemed critical. The adjuster accounts for potential errors in fee-for-service data, as well as the difference in how coding is validated between fee-for-service and Medicare Advantage. CMS claims fee-for-service providers submit fewer diagnoses. Therefore, no adjuster is needed. But in MA, there is the risk score coding intensity adjustment applied to the MA rates already. Are MA plans then being penalized twice, once with coding intensity and then on RADV? Sixth, the rule has a retroactive application and seeks to recoup revenues and payment years that were before the actual adoption of the RADV rule in 2023. The recoupment would go back to 2018. CMS says this is not truly retroactive as audits of claims significantly lag the year anyway. Plans argue they had no notice of the change in policy. Seventh, CMS argues that RADV's requirements to have MA plans submit documentation will be a payment integrity tool, but fee-for-service claims are accepted without this type of documentation. Save for some fiscal intermediary oversight, there is little scrutiny of claims in the fee-for-service system. Why shouldn't there be a similar process in fee-for-service claim submission, given all the talk of rampant fraud, waste, and abuse? With that, we will take our last break, and when we come back, we will continue with our discussion on the fairness of the new proposed process, discuss some additional possible reforms, and conclude. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you are enjoying this edition of the Healthcare Labyrinth Podcast. We are talking about risk adjustment in RADV audits. A recent announcement by CMS ups the risk to MA plans about recoupment of revenue in the MA program. So let's continue discussing the fairness of all these RADV audits. CMS's latest proposal could add to the regulatory muddle and will certainly compound plans' concerns. It could lead to more litigation on the 23 rule and what has been outlined for these audits. Consider this. CMS now says it will seek to recover uncollected overpayments identified in past audits. It also says the increased audit volume will help ensure CMS's audit findings are more reliable and can be extrapolated appropriately as allowed under the law. So, will Trump CMS be aggressive on extrapolation and recoupment, whether across all members or high-revenue subgroups? CMS also says it will deploy advanced systems to efficiently review medical records and flag unsupported diagnoses. Although it says medical coders will review during the audit, will AI-driven algorithms be used that focus primarily on suspect or high-risk areas or plans, which is a major concern MA plans have with the rule? Do truly random samples disappear? Will the samples be valid and fair? If not, extrapolation and retroactive recoupment is an even bigger concern for plans. I also question whether CMS can compete with the private sector to attract all the medical coders it would need to hit the targets and do this fairly. Private sector salaries are higher, and who in his or her right mind would jump to CMS given all the layoff news lately? I have some doubts there would even be enough coders if this becomes a combination of full-time staff and contractors. I also wonder how a legacy technology agency like CMS will procure and implement advanced technology efficiently and effectively. So, in the end, plans need to be worried about a few things. The 100% RADV audit announcement came quickly, and it is safe to say that many plans are ill-prepared to meet quick turnarounds for future rounds. Plans need to examine their end-to-end and counter processes for thoroughness and accuracy, look at potential wrong diagnoses being submitted, educate providers again on RADV, and perhaps run mock audits. Fewer records can now be submitted, which ups the ante on accuracy, timeliness, and completeness during the submission period. Generally, the suspect sample audit approach and extrapolation should be a major concern. In the 23 final RADV audit, CMS said it was, quote, not adopting any particular statistical sampling methodology in this final rule. As previously noted, CMS will use statistically valid methods for sampling and extrapolation that we determine to be well suited to a particular RADV audit, end quote. We have seen the negative impacts of these discretionary approaches from CMS before. A case can surely be made that legitimate sampling methods and even the extrapolation approach could be reasonable. Government deserves to oversee its contractors via efficient means, but not publishing sampling and extrapolation methods is simply not transparent, fair, or equitable. This is ripe for legal challenge in and of itself. Let's next talk a little bit before we conclude about existing and potential reforms beyond RADV audits. What has been implemented and could be done beyond aggressive RADV audits to address overpayments? We talked a little bit about lawmakers' concerns and what they may want to do, perhaps, in a second budget reconciliation bill. Well, here's an existing thing that has occurred and could be mandated to continue. It's the V28 risk model that was just implemented. The new model was created and implemented by CMS to rein in overcoding by health plans and target recognition of risk among individuals better. V28 will take more than 7% out of rates when the phase-in is complete for rate year 26. Models could be refined on an ongoing basis to curtail overcoding. Risk models could also be refined to include both prospective and retrospective components. Lawmakers could actually mandate these types of changes in the ongoing evolution of risk models. Next, there could be elimination of manual chart reviews and HRAs. Based on the evidence in several studies, many argue that risk scores, diagnoses that tie exclusively to HRAs or manual chart reviews should be eliminated. The argument here is that providers should be able to submit diagnoses via encounters to the plan if the diagnosis on a member is truly there. Next, there could be some changes in the coding intensity factor. The coding intensity factor seeks to adjust for differences between patterns in MA versus the traditional program. I don't really agree with that. It is currently set at a negative 5.91%. Some want to increase that adjustment factor globally, while others seek to apply the coding intensity factor on a plan-by-plan basis to take into account each plan's relative coding intensity, with a credible adjustment for real differences in risk based on population demographics. Given this handful of plans that actually abuse the risk adjustment system, I could actually get on board for differential coding intensity factor adjustments by plan. Next, another reform could be blending 2 years' worth of diagnostic data. This would be applied before setting risk scores. This could curb aggressive coding. And last, CMS could enact penalties for plans that do not provide complete, accurate, or timely encounter submissions. So let's conclude here. I do think MA plans need to clean up their act on risk adjustment practices. In most cases, what occurs likely is sheer sloppiness and lack of adequate controls. In others, based on whistleblower complaints, it may be willful and fraudulent activity as well as overly aggressive risk scoring. Each plan needs a comprehensive and accountable submission and validation process. The American taxpayer deserves this. But at the same time, MA plans should not apologize for having a business incentive to accurately document diagnoses for revenue when a diagnosis exists. Fee-for-service providers simply do not have the incentive in a transaction payment system. This alone requires that any RADV rule in CMS program is fair and equitable. As I said, while a case can be made that suspect auditing can be fair, it raises a real question about whether the industry will end up worse off with the suspect approach than a more comprehensive one. Plans should be most worried by the targeted RADV audit approach and how that ties to rigorous and ongoing 100% audits. Are plans at risk of greater extrapolated recoupment penalties and greater negative publicity by the targeted high-risk sample approach than if extrapolation occurred through comprehensive samples and auditing approaches? Does the government now conduct RADV audits in an Elon Musk Doge-like approach, stormtrooping for maximum recoupment to hit lower spending targets rather than a fair and transparent process rooted in real program integrity? Could we see too much off with their heads here? CMS's recent approach to star regulation and appeals, as well as its high-profile losses in court, are instructive as plans prepare for RADV audits and their aftermath. If CMS is to go this route, it should be judicious, be transparent, and recognize the huge fallout that could occur on an already beleaguered MA industry that is so crucial to Medicare's future, as well as the growing number of Medicare beneficiaries. With that, we will conclude this edition of the Healthcare Labyrinth Podcast, and we'll see you next week. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.